Wilms tumor. We will hear from Dr. Nicholas Cost, a surgeon at Colorado Children's Hospital, and from Dr. Elizabeth Mullen, a pediatric solid tumor oncologist at Boston Children's and Dana-Farber. You can see their full bios in the digital program book. Thank you, Dr. Mullins and Dr. Cost, for being here.
Thank you very much for that welcome, and I couldn't be happier to be joining today. I think this is a fantastic effort, and I'm delighted to be part of it. I think we have a lot to cover, so I'll move along. I will confess that I had set up my slides to be animated, and we're working through some technical difficulties, so the AV team is helping me. So it may be a little bit clunky, so please be forgiving. But today, Nick and I are going to give you an overview of the spectrum of renal tumors in children and young adults. That's the official title. And if you'll move to the next slide. I thought this was slightly more fun. So I stole this name of the talk from Nick. He talks about when he gets the call, and we're going to give you a little bit of a perspective from that of a surgeon and a pediatric oncologist. So I am starting first. So that's my part. There we go. There's the first animation. So let's move to the next slide. So I'm going to pose a little quick scenario. When you have a child who has an imaging finding of a renal mass, if you pause for a second, each of you might come up with something different for that first phrase. And that is likely to be probably Wilms tumor for most, simply because that's the most common pediatric diagnosis. But based on personal experience, you may think of other diagnoses. So we'll click through here, and someone might think about the next, which is renal cell carcinoma, malignant rhabdoid tumor of the kidney, congenital mesoblastic nephroma, or cystic nephroma, all pediatric and young adult renal tumor diagnoses. So next slide. So this goes to the when we get that call, what do we think about when you hear that first phrase? So first, we always have to think about putting that in the context of a real person, a real child, a real young adult. So then hopefully we meet the child and you start to try to move forward to obtaining what we want as a diagnosis to move towards a treatment plan. So the first step is to take a history. After that, we do a physical exam and then move on to do some diagnostic studies, which might include labs, imaging, and ultrasound, imaging of different sorts, which could be ultrasound, CT, MRI, and PET. And what we do is somewhat dependent on different scenarios. So, oops, that slide didn't come out well, but so how does the understanding of pediatric renal tumor epidemiology inform our clinical practice? That's what I'm going to give you an introduction to right now. So another friendly slide to talk about some different clinical scenarios. So with the global finding of just a child with a renal mass, that's very nonspecific, but put that in a different context. What if we have a prenatal finding of a renal mass? That makes you think of a particular type of histology and a way to aim your diagnostic workup. So that could be the next slide. A prenatal finding is very often a congenital mesoblastic nephroma. Yet if the patient that you see is a 3-year-old who has an asymptomatic mass, maybe went into a well-child visit or the parent was giving a bath, that's likely to be a histology of favorable histology Wilms tumor. In the next scenario, a young adult having hematuria and sickle cell trait will immediately make us think of renal medullary carcinoma as a diagnosis. A scenario of a 4-year-old child who's been limping, has some bone pain, and found to have bone mets would make you think about clear cell sarcoma of the kidney. If you have a very young child who, after in their evaluation, is found to have very significant burden of disease with lots of lung mets, it makes us think about malignant rhabdoid tumor. And if the child that you meet has a physical finding of hemihypertrophy, say one leg longer than the other, and the imaging says bilateral lesions, that makes you think of Wilms tumor with perhaps favorable or anaplastic histology. Moving forward. So how do we know that these things are associated, different clinical scenarios with different histologies? That is really the epidemiology that informs us. So just a quick minute to talk about the Children's Oncology Group protocol 3B2, the Renal Tumor Classification and Biology Banking Study, which has given us an insight into modern renal tumor epidemiology. This study was open from 2006 to 2025. Again, error on that slide, sorry. The study enrolled 7,935 patients, and patients up to 30 years of age were eligible. The initial study eligibility required only the finding of a renal tumor on imaging, so any pathology, any histology was eligible. And what the study tried to do was to define the incidence of various tumor types, to determine the association of patient and disease features with specific pathologies, and describe treatment approach and outcomes by histology across various age groups. And I have a few quick slides to show you some of those associations. So although Wilms tumor was the most common, patients presented with a wide spectrum of histologies. You can put up the curve there. So Wilms tumor, which is often quoted as being 90% of pediatric renal tumors, was actually favorable histology was only 75%. We found more incidence of other types of renal tumors, and the anaplastic was about 5%. And I've already listed all those other types of diagnosis. They all represented somewhat under 5%. So you can move to the next slide. We did learn that histology varies significantly by age. That gets back to the findings of our clinical scenarios. We found that 70% of diagnoses of Wilms tumor occur in children between 2 and 10 years. There are very few infants that had anaplastic Wilms tumor, and the incidence of anaplastic Wilms tumor, renal cell carcinoma, and renal medullary carcinoma did increase with age, and the diagnosis of CMN was almost exclusive to children under 3 months. Next slide. We did find that the presence of metastatic disease varied markedly with histology. So if you are found to have evidence of metastatic disease, you're much likely to have a other diagnosis than favorable histology Wilms tumor. We found that renal rhabdoid tumor of the kidney, was very typically diagnosed before age 2, and there were no patients that were over 10 years of age. And in patients under 2 years of age, although renal rhabdoid tumor of the kidney made up only 7% of the total patients, 31% of the patients with pulmonary metastatic disease had rhabdoid tumor. And we found that tumor weights and diameters were the largest in patients with anaplastic Wilms tumor and CCSK, giving us some, again, indication of what the histology would be just on the patient's presentation. Next slide. And we did find that the type of upfront procedure did correlate with the histology of the tumor. So most patients had an upfront nephrectomy, but the likelihood decreased of having an upfront nephrectomy with increasing age, and it did vary with histology. Next slide. So now is time for me to turn it over to the perspective of our pediatric surgeon, Nick Cost.
Well, thanks for that wonderful kickoff, Elizabeth, and continuing this theme. Next slide. I'll go through a little bit about what I think about. I should disclose my spouse works as a senior medical officer for Janssen, but I won't be discussing any of their therapies today. And Elizabeth and I both do serve on the Children's Oncology Group Renal Tumor Committee, but we're not acting on behalf of COG in this presentation today. Next slide. Next slide. I will include a variety of surgical images. So just as a warning, if you don't like anatomy or intraoperative pictures, I'll try to put a warning. Next slide. But I do also use dad jokes to break up my talks to hold people's attention. So I'll start with this one. What do you call 2 monkeys who share an Amazon account? Next. They're primates. All right, next. So again, just as Elizabeth has mentioned, there's a lot about the patient that we can learn based on some of the objective measures in terms of their age and their history and whatnot. Also how the image looks and how they present. Next slide. But I think that theme that every pediatric renal tumor is a Wilms is really not appropriate. And this alphabet soup of all these different types of tumors, they do exist. And these are things even that we've seen here at our institution over the last 15 years. So while they may not be as common as Wilms tumor, I think we have to keep our minds open when we meet a new family, a new patient, because the decisions we make can have important implications to their subsequent treatment and staging. Next slide. We talked a little bit about imaging. This is a bit of a drum that we've been trying to beat, which is that every child where there's a suspected mass, they don't need to go straight to get a CT scan. Many times, children that have a suspected mass in the abdomen, it turns out to not be any sort of malignant etiology at all. Maybe something as simple as constipation or hydronephrosis. And so starting with an abdominal ultrasound allows you to identify a little bit better what's going on, and then tailor the cross-sectional imaging, CT, MRI, to the most appropriate things. And we did a study a few years ago and found that there are a lot of unnecessary images being done in some of these patients. Next slide. As far as labs, there are some detailed things we want to know. In general, we get a broad panel of labs looking at blood counts and organ function, but we also want to look at coagulation because there is a known entity quoted at about 2% that children with Wilms tumor may have an acquired coagulopathy or difficult time clotting. And so obviously we would want to know that before we go to the operating room. And then also something that I try to preach to our trainees is that at this point, when you've gotten the call, it's really the moment to take a moment and think and talk to your colleagues, that there's no reason to rush unnecessarily. And you want to get all of the input of all of the people that could potentially impact the care for these patients. And that includes increasingly things like genetic counseling or even the idea of fertility preservation for some of our youngest patients. Next slide. A quick note on imaging, not all imaging is equal, and practicing in a place where we draw patients from a large geographic area, and a lot of times where they've maybe had their initial imaging done at adult hospitals, there can be subtle differences. And so, not all of the CT scans we see are equal, and sometimes we have to be thoughtful about it. Next slide. This is a patient who was packaged and sent down to us from Montana, and the story was that there was a large left renal mass, which I think you can appreciate here, and that they had done a CT scan of the chest, abdomen, and pelvis with contrast. Next slide. But when we looked at that, next, please. When we got the opportunity to look at that one, I don't really see that it looks very contrasted. If so, the timing was off, and there was something subtle that appeared in the right kidney as well. So even though we would love to, move through this part of the diagnosis, we did say we need to probably pause and redo the imaging. Next slide. And thankfully we did, because what it turned out was, in addition to that very large left renal mass, there was also masses on the right kidney. And so we treated this child totally differently. Rather than going to the OR as the first step to do a nephrectomy, this child received chemotherapy. And I know it may be surprising based on this image, but we were able to do partial nephrectomies, not just on the right, but also on the left as well. Next slide. Next. So in terms of surgical planning, sometimes we have to think before we rush in about what are all the things we need to do while we're in the operating room. That might include looking into the bladder and up the tube that drains the kidney, as sometimes the tumor from a kidney can actually creep down that tube, the ureter, and we would want to know the extent of that so that we got a complete resection. Next slide. Also, while many of these children will receive chemotherapy, not all will. And so we need to think, how do we appropriately take advantage of the patient being under anesthesia and combining surgeries when it makes sense, but not doing that unnecessarily? Next. And that can be very nuanced. And so we've tried to work our way through that. It may depend on the patient's age and their histology, their size of the tumor. And so we increasingly here use intraoperative frozen section once the tumor's been removed to decide, do we need to put a line in or not? And then also with that information, is this a child that could benefit from a fertility preservation procedure? Next slide. And next. So, some practices may be where the first part of the surgical case in this setting is to do a Metaport or venous access. Next. However, this was a case that had come the first time I was attending tumor board as a faculty here in Denver, and this was a case that a different surgeon had done. And there's a 2-year-old with a large left renal mass, and they had started with the Metaport there. Next slide. But surprisingly, the histology turned out to be a translocation renal cell carcinoma. Next slide. And the problem was that during the time that this child had the line, he actually developed a line-associated clot. So in addition to needing a second anesthesia to undo part of that procedure that wasn't necessary, the child also needed a period of anticoagulation, which is not without risk. And so, this is an example of where taking the time and thinking through that, could we have gained information in the operating room, for example, a frozen section saying it was renal cell carcinoma? That's a kind of tumor where we may not have great additional therapies afterwards, and so would more aggressive surgery have potentially been indicated. Next slide. And so next as well. So we've actually looked into this, and I think that we feel comfortable, at least at our institution, that using the intraoperative frozen section after the kidney has been removed, before we finish the case, that our pathologist can give us a good idea about what's going on, and then we can use that information as part of a larger decision tree to be able to decide who needs venous access or not. Next slide. So again, I think a lot of the message here is just taking time to think through everything you're doing and getting multidisciplinary input, whether that's with your radiologists or with your pathologists, with your oncologist, just taking time to think through it. Next slide. So as a quick joke, speaking of imaging, you may know that dogs can't operate MRIs. Next, but cats can. Next, please. So these children, again, they generally will present with an incidental detection. They may have pain, but that's less than half. They may have blood in the urine, but that's about 1 in 5. Many will have hypertension if you're looking for it. And some patients may have genetic syndromes or predispositions, just as Dr. Mullen already mentioned. Next slide. But then the next phase is that once we know that the child has a tumor and they're going to need, in many cases, surgery is the first part, we're going to then use the information from that surgery to stage them. Stage 1 is where that tumor at the time of the nephrectomy is limited just to the kidney. It's been completely resected. The lymph nodes that we sample are negative. The tumor didn't rupture before surgery or didn't spill during surgery. Next. Stage 2 would be similar with some local extension, either inside the kidney or into the renal venous system, even up into the IVC, as long as that tumor is completely resected with negative margins. Next slide. Next. So here are some images both of radiology and of intraoperatively of what this might look like. Next slide. So you can see, while these tumors can be quite large, as you can see on the right kidney and in the gross pathology picture, really dwarfing the normal parts of the kidney. They generally push things away. So you can see the bowel here, we pushed to the side as we resected that mass. Next slide. Stage 3, however, is where we start to see that there's residual tumor in the abdomen. Either that's because they had a biopsy as their initial procedure, and so the tumor is still in place, or there were lymph nodes that were involved, or a positive margin, meaning that there's likely tumor left behind, or the tumor ruptured before we got there, or was spilled or broken apart during the resection. Next slide. So stage 3, while not always, many times can have kind of a more nasty appearance at the time of presentation. You may be able to appreciate from these images, it's not just a nice round tumor. We start to see extension and pushing things more towards the midline. Intraoperatively, it may be difficult to peel the intestine, or the colon in this case, off of the tumor itself. Next slide. Stage 4 is where we're dealing with distant metastatic disease. And in this case, they're going to not only have the patient, the overall stage, in this case, stage 4, but they also will have the kidney, the abdominal stage will be factored in. That local stage will dictate potential radiation in the abdomen. And then stage 5 is the unique scenario where we're dealing with tumors on both sides. And again, we deal with a substaging such that while they may be overall stage 5, each kidney, the right and left, would get their own independent local stage. Next slide. And just some clinical images. Again, stage 4, often they're going to the lungs, sometimes to the liver. And while not always, many times they do have more advanced tumor in the abdomen as well. Next slide. And then bilateral tumors, just some clinical images. You can see here a large right tumor, a slightly smaller left tumor. Next slide. But overall, I think we would love for this number to be higher, but still we're dealing with overall survivals 90% or greater. And so that does indicate to us that we need to think about what is the morbidity of our therapies. And so reducing that where we can in patients that should have a good prognosis. Next slide. What's interesting, though, is the therapy, as you may know, really varies based on where you presented. So if you're in North America, most typically you're getting upfront surgical resection, whereas in Europe, generally they would be starting with chemotherapy. The UK for a while had a bit of a middle ground where they would start with a percutaneous core biopsy to try to determine who needed what therapy. Next slide. So I'll talk a little bit about what are the advantages of each of those. For the primary nephrectomy approach, we get the great advantage of having unadulterated pathology. So we know exactly what it was. It has not received, the patient and the tumor been exposed to chemotherapy. And there's a population of children that we recognize now could have surgery alone. So just a nephrectomy and not requiring additional chemotherapy. Next slide. As opposed to the European approach where they would give preoperative therapy to most all patients. And this would have advantages of shrinking the tumor, reducing the chance it may spill intraoperatively. It may enable things like nephron sparing surgery, partial nephrectomy. Also, it can give us some information about how did the tumor respond to that chemotherapy, which is very powerful in terms of prognosis. Next slide. And then the biopsy, again, the idea would be you could pick up the children that don't have a kind of tumor that needs chemotherapy or may need different chemotherapy. And fortunately, the complications from doing this biopsy are relatively rare. Next slide. But what's the disadvantage? Well, under the staging system here in North America, this would automatically upstage the patient to stage 3. And that matters because it would indicate that they would get adjuvant radiation and a more toxic chemotherapy, in this case, doxorubicin, with known cardiotoxicity. Next slide. What's interesting is that as the UK had looked back at their experience, they identified that in that age group of 6 months to 10 years of age, that the biopsy didn't add a whole lot of clinically meaningful information. And it did have an association with a low, but a real potential risk of local relapse. And so they now follow more European type guidelines where routinely giving chemotherapy without a biopsy, depending on the patient's age and presentation. Next slide. But I think that there is some bottom line that we have to look at, which is how do patients do regardless of which approach do they go. And there was a randomized trial done about 20 years ago that randomized a group of children that presented with a renal tumor to either have upfront nephrectomy or delayed nephrectomy. And fortunately, the survival, both the event-free survival and overall survival, were not different, which I think gives us some comfort. Next slide. So it's a dad joke. Poop jokes aren't my favorite kind of joke. Next, but they're a solid number 2. Next slide. So as a surgeon, I want to talk a little bit about what's involved in surgery. So we do this through an approach through the abdominal wall, going kind of anterior to posterior. And then we're going to feel around the tumor to make sure it doesn't appear to be invading any other structures, because our goal in the surgery is to get everything out all together or on block. Next slide. So some images from surgery. You can see here we've marked out the incision itself as well as the ribs. And in this case, after making the incision, the tumor many times pushes everything to the side. And in this case, it's already pushed the right colon over. Next slide. Sometimes that part of the incision itself is not quite enough. So increasingly for my practice for really large tumors, I'll use this combined transverse and vertical incision. Next slide. And that can give us a really good exposure. I'll point out some anatomic landmarks here. Next slide. So you can see here the inferior vena cava, next the aorta, next the liver has been completely pulled over so that you're actually looking at the diaphragm directly through the abdomen. Next slide. And so many times what we'll do is we'll start down low. In this case, the picture on the left, we're tying off the ureter and then we're pulling it up. And I just point out the large size of the tumor relative to the patient here, that these can be very large. Next slide. So some controversy that we'll try to get through quickly, the role of partial nephrectomy or minimally invasive surgery. It's well established that partial nephrectomy is indicated for children that have tumors on both sides, or if a patient has a predisposition syndrome. Next slide. Next. However, there are cases where, on a kind of institutional level basis, we'll make decisions about doing a partial nephrectomy. So this is a child who was a 4-year-old who presented after a car accident and had a scan for another reason. Next. And we saw a small renal mass. Sorry, this slide, it doesn't appear to show the picture. But we had an extensive discussion with the family. There you go. A relatively small renal mass on the right. And we elected that we thought it was reasonable to do a partial nephrectomy if we could get negative margins. Next slide. So some intraoperative pictures from that you can see here, where we've resected the tumor by using ultrasound, and then we've put that back together again. I'm mindful of the time constraints we have, and so I'll go ahead and ask that we wrap this part up here. I think, Dr. Mullen and I could probably go on for hours talking about this. Is something we think a lot about. I think in summary, the important parts is that while Wilms is the most common type of childhood renal tumor, it's not every child with a renal tumor. I think we need to be thoughtful about that, and we need to work with all of our colleagues in various disciplines, because there's a lot of us that would impact the care for these patients. And just want to say a huge thanks to Elevate and for KCA for inviting us to be here. And I want to say a huge thanks to my family for giving me the time to do these things. These are all the ways to get in touch with me if I could ever be of any help. Again, thank you all.
Thank you both. I think that was really helpful to the families on the call today, and everyone interested in renal tumors and Wilms tumor in particular. Before we jump into some questions from the audience, Dr. Mullen, could you share any changes that have happened recently to the protocol for treating Wilms tumors?
Thanks so much for that question. I do have a slide, if someone could pull it up, or a couple of slides here. So I am chairing a COG study for the risk-adapted treatment for patients with favorable histology Wilms tumor. And I'm going to very quickly tell you a little bit about that. But really, the most important thing is the why of doing this. So you will read constantly in textbooks about the outstanding, excellent outcome for patients with favorable histology Wilms tumor. But if any of you have heard me speak before, the only excellent number is 100%, of relapse-free survival and overall survival, and we haven't achieved that yet. Also, our treatments are too toxic, and really, we could only declare success if we prevent children from getting tumor to begin with. But that being said, our goals for this study is to use an expanded system of risk stratification to meet our overarching goals, which are to maintain or improve, hopefully improve our event-free survival for patients in each study cohort while decreasing acute and long-term toxicity. We want children to live another 8, 9, 10 decades after their diagnosis of Wilms tumor, and we want to live full and productive lives. So we are employing strategies of both augmentation of therapy for patients with higher risk of relapse and de-intensification of therapy. And if you go to the next slide, it looks at, you can click through. It's not all that complicated in that there is either patients get nephrectomy and observation or a number of the different chemotherapies there in the green boxes, which I won't go through in detail with or without radiation therapy. I didn't include a slide because you all just might leave about how you get to those different boxes, because the complexity of the risk stratification is enormous. I do have them in slides below, but I'll leave it at there just to say that this is an attempt to give our best 2026 version of personalized therapy for each child. So, how they present, what their tumor looks like under the microscope, what the biology is, and what clinical response they have are all helping us to decide what the best treatment is. We plan to enroll over 1,600 children over hopefully about 6 years and hope to move the needle forward. But even at that, again, the needle needs to move forward. We need to stop the development of these tumors would be the ultimate goal.
Thank you. I think that's very helpful. Dr. Cost, at one point you mentioned that there's no need to rush, so that we can bring in other groups within the hospital to take a look at these children. When parents are in this situation, they're obviously in all kinds of different states. Is there time for the parents to slow down, get a second opinion, understand their child's diagnosis specifically? Could you talk a little bit about a timeline for the need for intervention?
That's a great question. Thanks. I do think it varies from patient to patient, because patients may present in a very different way. So a child that presents asymptomatically, vital signs are all stable, then I do think that there's time to take over the next few days to really talk with the family about what's going on, what we think the next steps are. There are rarely, and I can't put a specific number on it other than I would say I'll see it about once a year, that a child comes in that does have a more urgent presentation. And this is generally because the tumor itself is bleeding and the patient may be a bit unstable. Generally, in that case, it's not a rush directly from the emergency room to the OR, but it is something over the next day that we're probably talking about going to the OR. So that timeline does get a bit more compressed. But outside of that setting where the vital signs are unstable and the blood counts are dropping, I think having a few days, even up to a week, to make those conversations and make sure the family feels comfortable about what the next steps are makes lots of sense, because I think there can be some decisional regret at times where they feel rushed into something that they weren't fully understanding of. Even if they ultimately would have come to the same decision, I think that they still want to feel like they were participants in that conversation and in that decision. And so it's really on us to provide them that time and space when it's safe for the patient. But I think for the most part, it is safe to take a few days to make that decision.
Thank you. I appreciate that answer, and I appreciate the parental involvement in that. I think that's very important. I did notice a few parents in our attendees list that experienced some relapse. Do you have any advice for those parents going through relapse treatments and initial steps there?
I'm happy to respond to that. I mean, I think that any experience of relapse is both incredibly difficult and very individualized. We have fairly standard protocols for upfront treatment, but we just, for any histology, haven't really achieved very clear standards for relapse therapy. So this gets back to the last question. I think pediatric oncology is a very, very collaborative world and space. And I do think that we're united in wanting to help children. And I think we are incredibly happy to enlist multidisciplinary input and sort of second opinions. The reality is that if you call someone and say, I have a child with X disease who has X relapse, no expert can give you you should do this. Second opinions need to be done sort of with full review of primary data and in a multidisciplinary way. So they can't be done emergently over the phone, but there is a network of doing this and there is a way to do it. And I think that children with experienced relapse should reach out to the sort of full network, and that I think providers are very willing to have that happen. Because it matters when you relapse and where you relapse and what therapy you've had before, and there's so many things. So I think that we're all very willing to work together in a very united, multidisciplinary way to do it, but it has to be with sort of review of primary data.
Sure. And I appreciate that. My experience with my son has been that many providers across different hospitals have helped us out. If there aren't any questions from our attendees on this, we are comfortable wrapping up. Dr. Cost, Dr. Mullen, we really appreciate you being here. Your insight is so valuable to us in the Wilms community. So thank you very much.
Thanks so much for the invitation. Sorry about the slide glitches, but we got through.
We did. You did an amazing job. Thank you.
Thank you.